My name is Shannon Chiu. I'm one of the Movement Disorders Fellows right now here at the University of Florida, so we'll go ahead and get started. I'm going to talk to you today about medications in Parkinson's disease. There will be a review of a lot of medications that we already have in our arsenal, but also a review of more recent medications that have been FDA approved, so are newer. So one of the big questions is, do I need medication? So as some of the talks previously have already mentioned, currently our treatment is really just for symptomatic control. We do not currently have a cure for Parkinson's or any medications that are neuroprotective, though a lot of research efforts are going into that. So currently our medications, when you start a medication, we want to try to help with symptoms and minimize side effects and improve your quality of life. So some of the questions that should come up when you're trying to decide is, if you have tremor, is it very bothersome for you? Is it interfering with your daily activity? Does it cause you social embarrassment? Is it painful or causing discomfort? If you have a lot of stiffness, are you having difficulty doing certain tasks because of that? If you're slow, is that affecting your daily activities? And are you not able to enjoy and do things that keep you happy and healthy? If your answer is no, and you're still doing, functionally well and able to do all the activities of your daily life, going golfing, for example, and doing everything, then at this point it may be that you do not need to start medications yet, because again, none of the medications that we have are going to actually slow down disease progression. But if your answer is yes to some of these questions, then it is time to talk to your doctor about trying a medication, because we want to improve your quality of life. So if there's something that is currently affecting your daily life, we can try what we have to try to improve that. So with the cardinal symptoms in Parkinson's, things like the resting tremor, slowness, deafness, difficulty walking, balance problems, the fundamental problem stems to one of the neurotransmitters in the brain called dopamine. And it's because with Parkinson's you have either a lack of the dopamine or not working well with the dopamine receptors, and so Parkinson's patients have these symptoms as a result of that. So the medications that we have all try to increase levels of dopamine in the brain in different ways, as I'll go through in a bit, and that's going to help with the motor symptoms, for example, in Parkinson's. So the combination of Carbidopa, Levodopa to date is the most effective therapy that we have for treating Parkinson's. The Levodopa is the critical component that actually provides benefit in the brain, and that's the dopamine component. And the reason we have the Carbidopa attached to that is the Carbidopa actually helps prevent breakdown of the levodopa in the body and the blood, so that actually reaches your brain, and it also helps to prevent side effects that you get with levodopa. So it helps to prevent stomach upset, drops in your blood pressure, and so when we refer to the Sinemet medication, it's a combination of Carbidopa, Levodopa. And then as you can see in this table, I'll go through each one of them a little bit more in detail in just a little bit. But you can see this list actually has been growing over time in terms of the different formulations that are currently available in combining the Carbidopa, Levodopa. They vary in terms of immediate release, controlled release, whether we use a special bead that helps to release the components at different times. We have intestinal gel that Dr. Burns mentioned before, as well as the latest inhaled Levodopa powder. So they all have different names and different doses. It can get a little bit overwhelming, but we'll try to review each one briefly. So the most common one, and the one that has been in our arsenal the longest, or one of the longest, is the immediate release, Carbidopa, Levodopa. Zenimet. Most commonly, it comes in the 25-100 milligram, but it is also available in a 10-100, but we use that less frequently. So in terms of going down the list of downsides, so sometimes when patients start this medication, they can get some stomach upset, nausea, and the way we recommend to combat that is you take it with juice or soda, crackers. And for a lot of people, it's actually okay to take it with meals, even though I think a lot of people read on the internet and you're taught that you should take it on an empty stomach. But from a practical basis, we actually have found that probably less than 10% of patients are really so sensitive to protein intake and meals that they really have to take it on an empty stomach. So for most people, especially if you have a sensitivity to medicines and are prone to getting stomach upset with taking meds, we say it's okay to take it a little bit of food just to help you tolerate it better. And then with higher doses, Zenimet can cause a little bit of drop in blood pressure, making you more prone to feeling lightheaded with when you stand up. But again, this is usually with higher doses, so not with a typical starting dose when you start this medication. This medication is okay for tremor, which we'll get back to in terms of the motor symptom that can be harder to treat. And then one thing to sort of dispel about the dyskinesias that patients, when they hear about Zenimet, they get afraid about starting this medication because they read that once you start this medication, there's a time clock that something like within 5 years of taking the medication, you're going to get dyskinesias. That's not exactly the whole story. It's really more complicated than that. And I'll show a figure on the next slide, and Dr. Burns alluded to this a little bit earlier. Much of it actually has more to do with disease duration rather than the duration of how long you're on the therapy per se, in terms of getting the dyskinesia. So,
Can you define that, please?
Sorry, yes. So dyskinesia describes when you have the involuntary wiggly dance-like movement. So classically, we say, you see Michael J. Fox on TV where it looks like he can't stop moving around. It's involuntary, and actually a lot of patients might not be aware of it, and it's caregivers and friends who notice it. But sometimes it can, affect your balance, and so that's when it becomes more bothersome. But usually with, if you're needing more levodopa over time and needing it more frequently, that can be a risk. And go ahead.
Is it permanent?
No, and that's a good question. So with medications, usually it's related to a reaction to the medication. So we can either adjust the dose, and then if that's not possible, down the line, if we've tried, let's say, reducing the medicine or adding other medications to try to treat the dyskinesia and it doesn't go away, deep brain stimulation can be helpful, but usually that's farther down the road once we've exhausted our efforts with medication adjustment. But it is typically reversible. So if, let's say, it's due to too much Zenimet that you're on it because you need it because you're otherwise too slow or stiff, if we back away on it, your dyskinesias might improve, but then you might have more trouble with slowness, stiffness, walking. So that's sort of the flip side of the coin, if it is essentially sort of a side effect of the levodopa. But I'll show you this next slide again, that it's a little bit more than just about, again, how long you've been taking the levodopa for that increases the risk. It's not quite that simple. And then another thing with this medication in terms of downside is, again, over time you may need more medication as your disease progresses. So people may need very frequent dosing. Some patients may be on it every 2 hours. So from a medication burden standpoint, that can be considered a con for this medication. On the positive side, this medication usually is very cheap. It's great for treating things like slowness, stiffness. It has a predictable on and off time. And usually for most patients, it is very quick in onset of action, but again, this can vary as your disease progresses. And then this medication typically is easy to increase and start over time, and we work up the dose slowly. And then again, since this medication really has been around for one of the longest time, it's really the tried-true gold standard in terms of therapy, right? Symptomatic therapy we have right now for Parkinson's, and studies consistently show that it provides the greatest improvements in patients' quality of life. So as I was alluding to earlier in terms of how your response to levodopa changes over time, much of this really relates to your disease progression. So early on in your Parkinson's, the window of therapeutic threshold is really much wider. You have smooth, extended duration of benefit. People get started on the medication 3 times a day and they don't really notice much change. They're just on it smoothly throughout the day. But as disease progresses, that window of when you hit side effect, but also how much you need for benefit, that window narrows over time, so that as you get towards advanced Parkinson's, the medication lasts shorter. You need more frequent dosing. There's much more sort of peak and dips, and then that window, again, of when you might, let's say if it's a peak dose phenomenon, you get the dyskinesia with the action movement. That window of when you hit the side effects becomes much lower, but then the threshold of how much you need for benefit, again, that narrows. And so part of that is also related to, you're losing the functioning neurons and the dopamine receptors over time. So it takes, again, much less for you to get side effects, but then you're needing more. So you're kind of between a rock and a hard place as a disease progresses. But this is why the medication regimen can get a little bit more complex over time when you need more frequent dosing or higher doses. So ideally, if we could have the medicine, with the ideal regimen, that you have as long of an on time as you can, minimize the off time, and one of the terms that you may hear your doctor say is they ask, whether you're connecting well dose to dose. And what we mean is, again, minimizing sort of that up and down and trying to maintain the good period when you're functioning well, moving well, minimal tremor, for example. And then, of course, our goal is always to avoid side effects. So we want to find you the lowest dose that works well, but with least side effects. So just as a quick pause here in terms of always having realistic expectations of what symptoms respond well to dopamine, what won't. Go ahead, sorry.
I didn't understand your last statement where you said take the lowest dose. Does taking more Cinemet cause more problems with becoming immune to its effects?
Right, so it's not tolerance per se. So our goal always at the very beginning is to find the dose that works best for you. So it's different, no 2 patients are the same. So one patient might do really well on just 1 tablet, but let's say another patient needs 3. So our goal is to find you the dose that is most efficacious for you, but without causing side effects. So usually there's no sort of, we don't necessarily have to make it 3 tabs for every patient, because going higher doesn't necessarily provide more benefit, because if 1 tab works well for you, 1.5 is not necessarily going to buy you more, but that might be different with another patient.
Thank you.
In saying mode, there is a milligram difference.
So usually when we do with the Carbidopa, Levodopa, the standard one is the 25-100. So the 100 is that Levodopa. Now there is a 25 to 50 formulation, which is the same as taking if you did 2.5 of the 25-100. So if you, instead of taking 2.5, if you, let's say, can do the 250, that would save you just 1 tab at a time. That is just your question.
Well, my question is, if 1 tab or 2 tabs works, does 3 tabs mean that you're going to have problems? Does it create a problem of itself, or what?
So not necessarily. Again, that threshold can be very different for different patients. So some, if with Parkinson's, we do know that, it affects different parts of your brain. So one of the circuitry it can affect is your gut absorption. So some patients may have slowing down of gut motility, and, in terms of absorption, some may need the higher dose because they need more of the pill to be able to absorb and get the same benefit. So for some patients to get the same level of benefit, let's say, if we do our scale and let's say we had to compare the score, one patient might need the higher dose to reach that same benefit, but for a different patient, a lower dose would achieve that same efficacy.
Yeah, I understand that part, but what I'm asking is, would taking 3 if you only need 2 make a difference to you in some way?
Can you overdose?
Oh, can you overdose? So no, so you can't overdose on this medication, but for some, let's say, if you do reach a higher dose and let's say you're with the higher dose, you can get the dyskinesias, the wiggly movements, or with higher doses, it might cause more stomach upset. So you might get side effects, but you can't overdose, not like pain medicines or other things where it would affect your function that way.
How often should your dosage be reviewed by the doctor? Once a year, every 6 months, every 2 years?
Right.
Is there a theory on that?
So usually when you start out, when you're starting on the medication, it's brand new and we're working up the schedule, initially we probably will see you a little bit more often. Say it might be, let's say you started brand new, we might want to see you back, say, in about 3 months just to see how you're doing, because we give you a schedule of how to work up slowly. But once you're on a stable dose, we could spread visits out to 6 months. And sometimes when patients are doing really well, let's say we've seen them back a few times with those 6 months intervals and your Parkinson's is just very stable, you're not declining, we could spread it out to, say, annual. We probably wouldn't spread it out beyond more than once a year visit. That's probably, if you're doing every 9 to 12 months, that means you're doing really well. But usually patients will be the ones who also will contact us and say, my Parkinson's is worsening, the medicine's not quite doing as well, and they'll be the ones saying, we need a visit sooner than the one you've made. But usually I would say, between 6 months or the 9 to 12 months is sort of the average. Yeah.
I see on your chart, it says gait speed, not balance. Does that mean that the Carbidopa has no effect on the balance?
Right. So, so the symptoms listed here, so slowness, stiffness, typically we expect to respond with the dopamine. Tremor can be hard to control. Again, tremor sometimes is one that may not respond so well to Sitimet or the other medicines that we have. And then fine motor skills improve. So in terms of with walking, so gait speed, mobility, the speed of, let's say, getting in and out of the chair, that may improve with dopamine and the levodopa, but things like balance, freezing, if you have a lot of freezing when your feet might get stuck when you try to walk or going through doorways, those are symptoms that typically won't improve. So when patients come to us and they're already falling a lot, they have propensity to lose their balance backwards. Unfortunately, at this point, no medicine that we have we've found to be consistently effective for this. Some patients may notice a little bit of improvement with levodopa, so I shouldn't say 0%, but in majority of patients, the balance issue, freezing, speech, swallow, if you have those difficulties as well, less likely to respond to medicine.
I know that in my case, my balance did deteriorate when I went down from my normal dose 2 per 3 times a day. I went down to 1.5 and I could tell the difference. My balance was much worse.
Okay. So it depends in terms
Depends
of,
on the individual.
yeah, right. And then again, if a balance, if a lot of it's due to freezing, that's one that again we say it can be hard to improve. But if it's part of it's the mobility, the flexibility that affects your balance that may improve. But again, some patients may tell you that their walking and balance are better, you know, with the Cinemet. But we just want to be upfront that if it doesn't improve, it doesn't mean that the medication's not working at all. Yeah, go ahead.
I found that the drug didn't improve my balance, it improved my ability to physically improve my balance.
Yeah, that's a really good point. So people say that they're able to exercise more. I don't know if that was what you were able to do more as well in terms of physical activity and exercise.
Good.
So that's a really good point. So it's almost like an indirect benefit. So yeah, that's great. So as you can tell from this figure here, there are currently a lot of different medications that we do have available to help with symptomatic management. They work in different ways, different receptors, but the goal ultimately, most of them still is to try to affect the level of dopamine in the brain, and they do that different ways. So I'll go through each category briefly. The ones highlighted in blue are the more recent medications that have been FDA approved. So one of the things, you know, so I talked about the immediate release Cinemet, our gold standard, but then, you know, the other question, once, you know, just the 3 times a day is not enough for you, you know, the question is, how do we make the medication last longer, and then how do we reduce the fluctuations so that you don't have the ups and downs throughout the day? So with the Cinemet formulation, there is a controlled release form. This, unfortunately, is not quite as predictable in terms of its efficacy compared to the immediate release. We still call it controlled release. And it's not quite as potent, so we say probably compared to the immediate release, only about 80% of the drug is actually bioavailable for when you take it, so it's not quite as strong. And then the use of it, though, is sometimes if with the regular immediate release Cinemet, if you're having problems, let's say, during the peak dose of it, some people complain about fatigue, or if you have a lot of the dyskinesias, the wiggling movements with the peak dose, sometimes we use this less potent form with the CR to try to reduce that sort of peak effect when the Cinemet hits, to try to even it out a little bit more. Another way we can use this medication is that if patients are having wearing off overnight or early in the morning, we give a dose of this controlled release at bedtime to basically bridge them till the next day. So they are still on the regular Cinemet during the day, but you take this at bedtime and they do a lot better. This medication can be broken in half, and then you can take it at the same time as the immediate release. So some people might be on a complex regimen during the day where they need a little bit of the immediate release, but they also need a little bit of the controlled release, almost like a basal insulin for those who have diabetes. So you can take it at the same time. So some people on the IR, CR throughout the day. But it does have a stacking effect, and so that's something to keep in mind. But we do use this very often, just like the immediate release.
What is stacking effect?
So just that in terms of like the medication, so again, it speaks a little bit to the unpredictability of the medication. So it, you know, might not have the same, you know, with the IR where we know in 3 hours it'll peak, and then, yeah, so the curve might not be quite that predictable. So if you take the medication repeatedly, you might have, it might have a little additive effect, but it just, you know, again, it won't be as predictable like with the immediate release. So Rytary is one of the newer medications for the Carbidopa Levodopa formulation. It's made with a special bead that basically releases the Carbidopa and Levodopa at different times and is slowly absorbed in your gut. So essentially it's kind of like combining the immediate release and controlled release, but all in one capsule, so you're not taking so many of the other ones. They come in a lot of different dosages, and it's not quite as potent if they compare head-to-head with just the immediate release Cinemet, But again, this might be an option for people if they're having a lot of the ups and downs and side effects with just the immediate release. This might be something to try to, again, to achieve a little bit more even efficacy throughout the day. Unfortunately, you still have to take multiple capsules typically per dose, so this doesn't reduce your medication burden per se. It's not one that you can just take once a day, unfortunately. And then this is another one that can have a little bit of that stacking effect. And then usually the way we calculate this is we look at, let's say we're converting you from the immediate release Cinemet. We'll look at how much levodopa you are on throughout the day in a 24-hour period, and we'll calculate what might be the equivalent dose of Rytary. Unfortunately, for a lot of patients, depending on what insurance you have, this can be quite costly, and unfortunately this can be the prohibitive factor for patients to be on this medication. So we're hoping that can change. Sometimes the patient assistance program does work for patients, so we always try that up front.
When you say stacking effect to me that means if you take more, then you get a bigger effect. Is that what you're saying, or is it, I'm not sure is that what you mean by it? You know, because stacking means you get more and more, or something usually. But I just want to make sure I understand what you keep saying when you say the stacking effect.
Right. So again, it sort of can, if you think of it like cumulatively with the dose, that it can be a little bit additive as you keep taking it in terms of throughout the day.
Your 10 a.m. dose is still active when you take your 2 p.m. dose? Is that what you're saying?
Right, so because the carbidopa levodopa, so in this where it's sort of released slowly over time, again, unlike the immediate release where you know it's in and out of the system, sort of like the control release, there's it's slowly released over time. I mean, the concept of it is it's supposed to buy you even time, but still, we don't know at any point how much of the levodopa is active and working and released. And so as you keep redosing throughout the day, some of it, right, your 10 a.m. dose, some of it, that capsule may be still releasing slowly, let's say, later in the day. So that's just something we keep in mind, you know, when we're dosing you. So Dr. Burns mentioned this briefly in his talk, the Inbrija, which is an inhaled form of the Levodopa powder. This is approved now and on the market. It was approved in 2018. It's meant to be used as on as needed basis to cover when you have unpredictable off times, or let's say you have wearing off early in between your dose. This is basically like a rescue medicine. It doesn't replace your Cinemet or whatever medication you're currently on. You can take it up to 5 times a day. And then sort of like an inhaler, if you have lung problems like asthma or COPD, we either avoid or you just need to be very careful and talk to your doctor before trying medication like this. Similar side effects as Cinemet, but it can also cause cough and change in your saliva color. So just be aware of that if you are using this.
What do you mean by change in saliva?
The color, yeah, because the powder, it can just affect the color.
What color does it make it?
Orange and blue.
Yeah, I don't know if it's those colors. I want to say it's kind of like almost brownish, something like that. I'm actually not sure. Darker, yeah. And then another class of medication, these are, I'll review 2 that are currently on the market, are, again, these are add-on medications to try to prolong the half-life of Cinemet. So one of them here is called Entacapone or Comtan. So you never take this just on its own because by itself it doesn't really have much efficacy. And you take it with every dose of the Cinemet. This, in terms of changing colors of urine secretion, something to be aware of, this can turn orange. And then for some patients, when you add the Entacapone, it can make your dyskinesias worse. So that's something to bear in mind. I'm going to zip through a little bit faster. So this is another form, very similar to entacapone, but we rarely prescribe it now because of liver damage.
Those are the ones that stop the breakdown of the enzyme that breaks down the...
Right, of the levodopa, right. So again, the mechanism is to increase the availability of the dopamine in the brain. So this one is the actual brand name where you combine the Cinemet with the Comtan all in one pill. And again, the thing to watch out for is dyskinesias. This can worsen in some patients. Dopamine agonist is another class of medication. It mimics the action of dopamine, not quite as strong as Cinemet. For people who have restless legs, this can actually be very effective. We do see restless legs a lot in patients who have Parkinson's. But side effects that you have to be aware of is things like swelling. People can have excessive daytime sleepiness, falling asleep at the wheel, have to be careful about that. It can drop your blood pressure a little bit. And then one thing that we always ask, and if any of you are on dopamine agonists, it might seem strange when we ask about it, but because it's a side effect, impulsivity, so people can have excessive gambling, eating, hypersexuality, shopping, spending, and it is dose dependent and reversible, but usually as you go higher up, the riskier it is, so we always ask about that. And then in older people, we also worry about risk of confusion and hallucination, so these are definitely side effects that you need to be aware of if you're starting it. So there are many different kinds. Pill form and the Mirapexin Requip. Nupro is in a patch form. And then Apokyn and Joctazol included here because the mechanism of it is a dopamine agonist, but this is another one that you do as needed, as a rescue. So on its own, you don't just do Apokyn injections, but again, if you have unpredictable wearing off, or in the middle dose you need a little rescue, you can use this medication. And then another class of medication, MAO inhibitors. So the MAO-B, another enzyme that can break down dopamine. So by inhibiting that, you're going to increase the levodopa. So we have many different forms. Sulfonamide is one of the newer ones that have been FDA approved. It can be for more advanced Parkinson's with motor fluctuations. This class of medication you can use on its own in early milder forms of Parkinson's, but more often we use this as an add-on. It has a mild modest benefit to motor symptoms. But one thing I'll just highlight at the bottom is that when you're on this class of medication, you need to be aware of some drug-drug interactions if you're on some pain medicines or St. John's wort, Robitussin, over-the-counter decongestants. There can be some drug-drug interactions, so just make sure that you review your medication list with your providers. And then I'll just mention with the Rasagiline that one point, there was debate whether it can be neuroprotective, but data is sort of inconclusive, but we do have a study that was conducted here at the University of Florida, along with imaging correlate, and we're looking to see if Rasagiline can be neuroprotective. So data hopefully will have available later this year. And then just a quick word about anticholinergics. This is one of the oldest classes of medicines. We try to avoid actually in older patients, especially those older than 70, because of the long list of side effects, as you can see here. But for younger folks, if it's tremor or dystonia, which is abnormal pulling, posturing, things like toe curling, foot turning in, sometimes a medication like Artane can be effective. But again, for older patients, we try to avoid this because of side effects with this. And then quickly, in terms of for other medications for Parkinson's, so amantadine's one that when it first came out, it was found to be beneficial for tremor, but more recently we have found it effective for dyskinesias. And more recently, there have been a few more formulations, extended release formulations of amantadine that have been approved. Gocovri is one that's FDA approved specifically for treating dyskinesias. And then Osmolex is, again, very similar to the amantadine, except that you can just take it once a day. And again, if People have bothersome dyskinesias, as let's say due to the amount of levodopa they're on. These can be effective medications. But for amantadine, some side effects to take note of is that it can cause things like hallucinations, and there's a unique skin change, purple, kind of red, blotchy, lacy appearance that can be associated with amantadine's libido reticularis.
Don't drink.
Say that again?
Don't drink with it.
That's a good point. And
What
then,
is extrapyramidal?
so dyskinesia is sort of included as one of the features. Right, that doesn't have to do with the pyramid. But a lot of the Parkinson's symptoms, actually, we call them extrapyramidal too, in terms of with the slowness, walking, the rigidity, and all of that. They just didn't FDA specifically say dyskinesia, because Gocovri and Osmolex at the time were sort of competitors, and then Gocovri sort of won, or came up first for the specific indication for dyskinesia, and then Osmolex sort of used that umbrella term with extrapyramidal to get their approval, but essentially it includes things like dyskinesias too. And then this is the newest medication that's just been FDA approved last year for Parkinson's. It's another add-on medication, meaning you usually take this along with your other medications. It's been shown to be effective in decreasing off time. It's dosed once daily, and then some similar side effects to Sinemet. This one works a little bit differently from the other medications. It's an adenosine inhibitor, so just another enzyme, but ultimately, again, it works on the motor pathway in Parkinson's to try to improve function and reduce off time.
But does this have anything to do with levodopa, or is it totally different?
It's actually different in terms of mechanism. The precise mechanism actually not entirely clear, but it doesn't act on levodopa or dopamine.
So you wouldn't use this one if you're already on amantadine? Would they then get you down from amantadine and ratchet you up on that one?
Right, so it depends on what you're trying to treat. So if you're trying to reduce off time, if your amantadine's on board because of dyskinesias, because with the peak time, you may still need the amantadine for dyskinesias, and then this is more for reducing the time when you're off. So you may need both because you're trying to tackle it, different aspects of your day. I think close to being done. So just a quick page forward in terms of using Parkinson's diary to keep track of your medications is very helpful to know what symptoms you're having, benefits, side effects in relation to the timing of the dosing, so that you can, when you go to see your doctor, we can adjust the regimen accordingly to see when you're having your off, when you're having your dyskinesias, etc. And I just included Botox here, not as a Parkinson's medication per se, but it has a lot of applications in Parkinson's. Just for the sake of time, I'll keep going, but if people have more questions, feel free to ask afterward. And then advanced therapies, I just included this in this talk just briefly, since there are a lot of symptoms, especially as your disease progresses, that oral medications will not be enough to treat, so there are other therapies available to manage that, like if you have really bothersome refractory tremor, dyskinesias that we can't manage with medications. There are advanced therapies like the dual intestinal gel and the deep brain stimulation. And then quick preview for Dr. Moore's next talk is so far all the medications I've reviewed are specifically for motor symptoms of Parkinson's, but we do know that Parkinson's affects so much more than just the mobility and the tremor and that part. So cognition, memory, mood are all affected. So Dr. Moore will be talking about that next. So take-home points. Treatment is individualized, as some of you have already pointed out. What works for one person may not work for another person. Your medications are likely to evolve and change over time as your disease progresses. It's helpful to keep a diary and always watch out for side effects and make sure your doctors are aware of them. And then last but not least, exercise is one of the most important things that you can do. So we already had a pitch for the rock steady boxing, and then someone's talking about Tai Chi. So there are lots of different things that you can do to increase your balance, mobility, flexibility, stretching. So all of that's very important. Right. So additional resources, and then we'll have Katie come up because I don't think we have time for. Okay, we'll do that.
Just expound a little bit on the word dyskinesia.
Uh-huh.
What is that really in common language?
So you mean the description of what it looks like, or?
Well, I see it referred to a lot, dyskinesia.
Mm-hmm.
What does it mean?
Well, so essentially it has to do with the, I guess on a mechanistic level.
In other words, the symptoms of the dyskinesia. There's different symptoms.
So the symptoms, just when we use it to describe when patients have involuntary, like sort of wiggly movements, that's what it looks like.
Not just tremors.
So not tremor, right. So it's not rhythmic. It's usually, so commonly people can have in the head, neck, or trunk. Sometimes they can have in the legs too. But it's not a predictable rhythmic movement like tremor. Yeah.
Michael J. Fox's kids were having friends over, and their friend said to him, "Can't you sit still?" That's it, isn't it?
Yeah, exactly.
Can't sit still.
How are you going from on to off? Is that a quick thing, kind of, that you should notice dramatic changes? Or is it more subtle?
So that's a great question. So early on the disease course, a lot of patients don't experience that at all. So when you're on the medication, they just feel the same throughout the day. So when later on, it can manifest in different ways. Some people will say they know they're starting to need the next medication if, let's say, tremor starts to break through. Some people will describe they start feeling a little anxious. Or some people will notice they're starting to slow down and they're walking, they start to shuffle a little more. Usually it's not sort of like an instant, just not like a light switch where they just suddenly turn off, but it might be like, let's say half an hour before the next dose, they start noticing their mobility or let's say anxiety. Something changes a little bit.
Like maybe more passiveness?
Yep, some people can describe that, or some people will notice they, I think spouses have sometimes mentioned their facial expression sort of changes.
Depression?
Depression, so sometimes it can be hard to tell how much of that is, and Dr. Moore will talk a little bit more about that. So the key is, is it time locked with your dose? So if your mood changes predictably, let's say just before the next dose you start feeling down or you start getting more depressed, then it may be wearing off. But if it's not so predictable, then it could be just your depressed mood more at large and not necessarily the fluctuations of the levodopa. Yep.
What you normally take?
Sorry, go ahead.
What you normally take meds every 4 hours, but then you notice you're on and off more. Could you have it and take it every 2 hours?
Right, so when you do that, if you, let's say, lower the dose, what you might notice is that your benefit might be a little bit less on the lower dose. Usually, if, let's say, you're starting to notice that the medication doesn't quite last as long, we might just try to tighten up the dose a little bit. So instead of every 4 hours, we might make it every 3 hours because you're wearing off early. There's no point for you to make you suffer and wait that extra hour, so we will push it close together. So there is, what we call young onset Parkinson's. So in the literature, there is some variable definition in terms of under 40. Some say it could be 45. So usually we notice that for patients who get younger, there may be a genetic predisposition, But Parkinson's can hit you earlier, but usually we say if it's the classic typical onset, it's usually the older, once you're above 60, 70, that's probably more typical onset. All right, I'm sorry there, we'll save the
It's
question.
not a question, it's a statement. I'd like to thank you, doctor, for being so articulate and putting things in terms that we can all understand.